The fundamental pathology in a polar cataract is that, one, we know we've got a opacification of the posterior pole. Two, we've got an abnormal adhesion between the posterior pole and the posterior capsule. And equally importantly, we have an abnormal inherent fragility or weakness of the posterior capsule, right? Unless documented preoperatively, almost always in my limited experience, I have found that the opening that occurs while operating on a polar cataract almost always happens intraoperatively. And what I mean by that is because of some manipulation or the other, at some point or some stage, because of the forces within the eye, the PC gives way. Very infrequently, seldom you might see a case like this where you actually see a preoperative opening on retroillumination, and this could be, also the diagnosis could be augmented by using a UBM. Getting us to the point of realizing that the surgery is the key, and the technique and the tips that you can use to make sure that you get an optimal end result with an intact posterior capsule to the best of your ability. So to start with, when we talk about the incisions, you don't want them to be too tight because you don't want, instrumentation difficulties moving in and out of the eye. You don't want them too wide because you don't want chamber fluctuation. You never want your PC to come anteriorly throughout the surgery because it can just give way, and it sometimes does. And your rexus should be an optimal, like a 5 millimeter, so that should you have an opening in the posterior capsule, you now have a sulcus where you can place the lens. You also have an option of placing the lens in the bag with an anterior optic capture, or a 3-piece lens in the sulcus with a in the bag capture. So coming to the next thing, so the most important different thing that you do here is a hydrodelineation. After decompressing the anterior chamber, the hydrocannula is inserted at a particular point. Often in a soft cataract, we determine the point at which we inject. So we determine the size of the endonucleus. We also determine the size, therefore, of the epinucleus, which protects the eye. Often these cataracts are soft. So in this particular case, the surgeon just virtually in the foot pedal to the aspiration mode aspirates the entire cortex. And now the epinucleus is also just jumped up, and so that is also aspirated. Yeah? In the next case, right, and this is most important, you do not want your chamber fluctuating, so you always do a fluid visco exchange at the end of your nucleus disassembly. In this case of a polar cataract, again a grade 1 polar cataract, you see the hydrodelineation. We decide how small the endonucleus needs to be. Again, it's soft, and the surgeon, again, only in the aspiration mode, in a piecemeal, is just aspirating most of the endonucleus, followed by a visco-BSS exchange, checking to see is there any opening in the posterior capsule. And this is one way in which the epinucleus can be managed. When you do a visco-dissection in a relatively collapsed bag, we don't have a nucleus there. You're not likely to cause further pressure effects on the posterior capsule. Doing a visco-dissection just prolapses the epinucleus into the center, after which it can be aspirated. Following irrigation aspiration again, and before putting in the lens, you do a visco-BSS exchange. This is a case of an eccentric polar cataract. I haven't seen too many of them, but they do exist. Here again, the entire endonucleus is just brought up and then aspirated, right? I'm just going through the different grades of cataract. Now, as the cataract grades get a little more dense, things change. This is a case, again, with a smaller pupil, so it makes sometimes visibility in and around the periphery a bit of a challenge. As long as the nucleus keeps prolapsing up, or sometimes here with a little bit of a help, you can just bring it up and aspirate it, followed by the other steps, management of the epinucleus in the two manners in which, so this is the other way. So one was a visco-dissection, and this is the other way, where you go in your epinucleus mode settings, hold on to one end of the epinucleus. The epinucleus is thickest at the equator, so somewhere you got to get a hold of it, and then you start pulling it, creating a break in it, and finally ending up with removal of the cortex. Now, as the cataract grades get slightly harder, the challenge comes in doing a hydrodelineation. When you go to actually inject, this is not that hard. The tendency is for it to go towards the subcapsular area, so you have to exert significant caution. Then again, if the nucleus does come up, you need to take a call whether you want to do a chop in the salute, a phacosalute, where in a lifted up position you want to chop, which is happening here. At each stage, if you do have the ability to check on stereocoaxial illumination, you want to check whether there is a break, because then the way you would manage those cases will be different. And in this case, the surgeon does a direct chop in the bag. Now, when you're doing a direct chop, I think it's important not to do too much of a lateral separation, because the forces exerted on the bag then again can cause a split in the posterior capsule. I think that's it for this video. So, I have seen several times that even after irrigation aspiration, if you were to bring both your instruments out of the eye without doing a viscofluid exchange, the inherent fragility of the posterior capsule sometimes just gets it to give way. In this case, the surgeon has done a direct chop, but without rotating has managed to just bring one half up. In this, I find that using the Kelman tip helps you chop in situ because of the curved angle of the tip. And once you've got your fragment, so at least if you've got one fragment and you've decompressed it, then you have room for that rotation not to cause too much of a pressure on the posterior capsule. So once again, checking that your PC is still intact. I think we can go to the next. So now I'm just going to show you a few situations where you can have a posterior capsule which is open. If you see here, this is a typical look in a polar cataract where it is not an opening in the posterior capsule, but it's just a condensation of the posterior vitreous. As opposed to that, if you see in this video, you see the fish mouthing of the, it's showing, right, the videos, yeah. It's showing the fish mouthing. In this particular case, at the end of irrigation aspiration, the surgeon actually notices the two linear lines. This is typically what an opening in the posterior capsule looks like, one end of the equator to the other. But because there is no vitreous disturbance in this particular case, the surgeon can consider attempting putting even a one-piece lens in the bag at right angles to the opening. Now, in this case, the surgeon, while bringing the last bit of epinucleus out, actually notices a significant fish mouthing and therefore decides to stop after aspirating that, but comes out, carefully doing a fluid visco exchange, but still there is a further enlargement of the dehiscence. There is obviously a vitreous disturbance, and then the surgeon proceeds with doing a limited anterior vitrectomy, first in the incision, then in the AC, then in the area of the open posterior capsule. So there's a play between cut IA and IA cut. Once you've cleared the vitreous, then you can go in the IA cut and aspirate the cortex. In this case, there's a pupillary snap sign, and so the surgeon thinks that instead of getting the nucleus to sink down and then manage it and manage the patient later, decides to bring the nucleus in the AC. Honestly speaking, today, if it was a cataract like this, I would steer away from doing any kind of nucleus management in the anterior chamber. I would rather let the lens go down. I'll show you how we'd manage it. In this case, moderately hard, a cataract. At the end of, because of a significant lateral separation, the nucleus is starting to sink. This again is a video almost 8 years ago. I'm actually showing it because this is something which I would think you shouldn't do. If you, the surgeon has attempted to put in a needle through the pars plana and levitate the fragments, but you don't know what you're doing to the base there. This is how I would manage a drop fragment today, or a dropping fragment. This is a grade 3 polar cataract which is being managed fairly well, but in front of the surgeon's eyes, one fragment chooses to go down. So what you do at that point is you reduce your settings, put a dispersive viscoelastic, if possible, emulsify the nuclear fragments without disrupting or dislodging vitreous. However, as you can see, vitreous is disturbed here. So surgeon, then now a fragment has gone in. However, you don't go chasing that fragment or trying to lift it up. You do a limited anterior vitrectomy, you remove the cortex, you put an IOL in the bag, and you suture all your incisions, because that's what the VR people need, and hand it over to them to manage at a later date. And finally, because of the inherent fragility in the posterior capsule, posterior capsular polishing perhaps is not the best of ideas. So if you do have an opening while doing capsule polishing, it's best to try and convert it into a central PCC. And here the surgeon actually takes a 3-piece lens and places it in the bag. And my final video, it's really not over till it's over. In this particular case, the surgeon actually at this point is doing a stromal hydration and fails to notice that actually just an overpressurized globe during stromal hydration and otherwise uneventful surgery has resulted in this in the postoperative period. Right, with that I come to the end of my talk. Thank you very much.